in cells, we can burn a lot of different fuels for fuel, right? We can use our sugars when sugar is around, or glucose. We can use fatty acids. So cells are really robust in what they can do. But where does that energy production happen? It's in the mitochondria of cells. And mitochondria actually kind of dictate what's going on in that cell. When they start to get stressed out or damaged for some reason, they actually start to send out some stress signals, even to the nucleus, which can tell the nucleus, you're a different cell now. You need to do things differently. But as mitochondria become more and more damaged, they tend to now, instead of using mainly fatty acids for fuel, they convert more to using an anaerobic pathway. So even though oxygen might be around, they start to burn glucose preferentially, and they need more and more of it to sustain themselves. So it kind of, the cell transitions into the every man for themselves type of cell. When cells are healthy, we're all living in a community. We're doing our jobs. The liver cells are doing what liver cells need to do, and they're taking up only as much space as they need. But as cells become damaged and they start to revert back to kind of that single-celled organism mentality of, I just am here to survive until tomorrow. And how do I do that? And the cells start, because they need more and more glucose, and again, in this kind of anaerobic metabolism, even though oxygen is present, and this has been named or known as the Warburg effect, which many of your listeners, I'm assuming, have heard about. But this Warburg effect, these cells now are behaving differently, and they start to upregulate their insulin receptors. So insulin receptors are on the surface of all of our cells. So when glucose is present, insulin is released from our pancreas, binds to cells, tells the cells, hey, there's glucose around. Okay, let's pull some glucose in. But these cancer cells are these damaged cells. So it happens even before cancer becomes present. We have this process. So we're in cancers, when we have very low grade or even kind of benign tumors, we have some of that damage happening. And as cells become more and more aggressive or highly proliferative, or growing fast, they need more and more of this glucose to do that. And so they upregulate insulin receptors. Again, insulin's the key to the door, pulling that glucose in and telling the cell, hey, there's a lot of glucose out here. So the cancer cells then use this glucose, these carbon molecules in the glucose structure, to build new cells. And these insulin receptors, or these insulin signals, are further growth factors for the cancer cells. So the cancer cells being told, hey, there's lots of glucose around, bring it on in and let's use it. Whereas our normal cells, they can use glucose if we need to. If we're in an anaerobic state, we're doing a 100-yard dash and we're sprinting, we're doing muscle, weight training, and that muscle fatigue, we feel that lactic acid burn. We are in an anaerobic state and we're using glucose. But at some point, our brain says, hey, take a break, breathe, let's get oxygen back to the tissues, let's heal, let's get back into our steady state of mostly using our mitochondria to create nice fuel using different pathways. So again, as our cells slowly become more damaged, it's usually a function of mitochondrial damage that happens over time. Toxins in our environment can cause damage. The drugs we're given, even, good pharmaceutical drugs for some chronic disease we have, might slowly be actually damaging those mitochondria. Food, we have the fake food environment. We have, processed seed oils and highly refined grains and sugars, high fructose corn syrup. We have lots of toxins in our food environment. Somebody who's already starting to have some sluggish metabolism, some broken down mitochondria, if we're constantly in a high carbohydrate, high sugar, high inflammatory fat environment, we're actually compounding the problem. Bam, bam, bam. But we can get it, from anything that creates imbalance in our bodies, if we start to become completely sleep deprived, and sometimes that's because that's now driving more insulin resistance. It's driving, us to eat a different way because we're just trying to stay awake, or we're pounding, Red Bulls or something. We all know that smoking is a mitochondrial toxin. I mean, we've talked about smoking causing cancer for decades, but all of those lifestyle habits that we know maybe aren't quite so good for us really do take a toll on our cellular health, which can then predispose us to those next set of chronic diseases. And I don't treat cancer like a special disease, even though I'm a cancer doctor. It's no different, in my opinion, than somebody getting diabetes or, cardiac disease or other things. These are all mitochondrial dysfunction diseases. And I kind of feel like, well, maybe our genetics predispose us to which of these diseases we might get. But if we really pull ourselves back to that root cause, really they're all coming from the same things. And I don't want to cloud this with, cancer's a genetic disease. It's certainly, we know that if we truly look at it, even from a conventional standpoint, how many cancers are genetic, it still is a very small percentage. But if we go upstream, why is it that only some BRCA1 or 2 patients get breast cancer? Why don't all of them get breast cancer? Well, because some are maybe using better diet and lifestyle tools and optimizing their mitochondrial health, and they never get the disease. But we don't go that far in conventional medicine to really look at, okay, why did these people get it and these people don't? We just say, oh, it's in your genetics, therefore you're more likely to get it. When we eat a ketogenic diet, we are significantly ratcheting down our glucose in the system. So we're eating very little carbohydrate, which is broken down into glucose, which can then stimulate insulin. So now not only are we bringing down glucose, we are bringing down insulin. So what has been shown in numerous trials is women or men, depending on the study looked at, but those who have higher insulin levels have higher risks of recurrence, have higher risks of metastatic disease, have higher disease stages at the time of diagnosis. So what we know is that if we have lower levels, those things are not as bad. There's actually data, yes, even in humans, we know we don't seem to hear about it very much, but even some small studies looking at humans putting cancer patients on ketogenic diets, or maybe not what is typically known as a ketogenic diet, but other fasting mimicking diets, because there is some distinction out there, although really the bottom line is getting a person into a metabolic state that is creating ketones. So any fasting mimicking diet, in my opinion, is a ketogenic diet. But that being said, in these studies, it seems that the therapies are significantly augmented. Even stage 4 patients who maybe aren't expecting any big drama, in they're just trying to, so there's stage 4 colon cancer patients that were put on ketogenic diets or standard of care. And those patients on the ketogenic diet in stage 4 that really just were getting chemotherapy, it was kind of palliative chemotherapy, so they weren't expecting any cures. And I'm not saying that any patients were cured, but the response rates were dramatically better in the ketogenic diet. In fact, 50% of those patients had complete responses to the diet with their standard of care palliative chemotherapy versus standard diet and chemotherapy. And in the standard diet group, 0 patients had complete responses. Now, some of them had partial responses, which is great, but the power of adding that. So why is that? When we feed our normal cells ketogenic diets, they operate just fine. They can operate any which way we want to do it. And we're keeping them healthier by not bathing them in high glucose states. But very interestingly, when we follow a formulated ketogenic diet, so we're not saying bad fats like those seed oils and salad dressings and mayonnaises typically at most grocery stores, but really optimizing the natural fats that come in our animals, and maybe some olive oil or coconut oil or other I always say fruit oils as opposed to vegetable, nut, and seed oils. But when we optimize those foods, we're not bathing our healthy mitochondria in toxins. We're removing a lot of those foods that create the problem to begin with. And because those cancer cells have damaged mitochondria and they need more glucose, they need that insulin signaling for growth, we're taking that away, or we're keeping it extremely limited. So now we're taking away, and we will always have glucose in our system and we will always have insulin. So when we say we're starving cancer, we can't shut it off completely. We need it to live, but can we make those cells so fragile now that our therapies work so much better because those cells are so ready now to be killed by whatever therapies we want to use, whether that's conventional therapies or other oxidative stressors to those cells. We can really enhance that effect when we put the stress on those cancer cells, take away their preferred fuel, or at least ratchet it so far down that, and when we're burning fatty acids, we're shutting that, even though there is some glucose and insulin in the system, we're actually shutting it down further. So really all studies at this point, at least the ones that I can find, are either there's a chemotherapy trial with water fasting. There's chemotherapy trials with severe calorie restriction fasting. And because those are not sustainable, they were only doing them around the chemotherapy. So a day or 2 or 3 or 4 around that dose of chemotherapy. The beauty of a ketogenic diet, right, is that we get into a fasted mimicking state. Sometimes we can do a little calorie restriction or fasting around our chemotherapy, but we can then continue it day in and day out for our entire course of therapy. Maybe we're going to stay in a ketogenic state for 6 months or a year. Some of us, many, many, many years. I wish that we were looking more closely, but right now, I just wish that the conventional world was even looking at this Warburg idea more robustly. I think there's so much data and really so much pathophysiology that we can say, but this should really benefit a patient. I work with patients every day, and most of the time, the next day they're like, oh my gosh, I feel so much better. It's like within days, they're like a light switch has flipped and I finally feel great, even though I know I still have cancer. Just my energy level is better. My joints are better. Like they're already feeling better. And I lost that extra 30 pounds of fat mass that I had right in my belly. So that you can see people get healthier. So I don't know why there's such the resistance in most conventional medical offices when we're talking about diet and cancer. Most of the time it's don't lose weight while you're going through therapy. Don't do that crazy ketogenic diet. You're going to, have a heart attack or something. Trials that have looked at that have either used water fasting or severe calorie restriction fasting around chemotherapy. And those patients tolerated chemotherapy better. In fact, in the fasting mimicking or the restricted calorie diet, the patients didn't even take the steroids that are usually given in conjunction with chemotherapy, which then, of course, drive up sugar and insulin. So those patients that were doing the fasting mimicking diet did not have steroids and still had better overall symptom scores. The one that was using water fasting in gynecologic malignancies, they had less need for dose reductions. They had less hospitalization. So definitely can help protect in that state. Now, when we're fasting or using calorie restriction for fasting mimicking, what we're doing is we're pulling fuel for our normal cells from ourselves. We're pulling it from body fat. So we're still eating, but we're eating ourselves. Sometimes we do have quite cachectic patients. That means very little fat and maybe even little muscle. In those patients, I find that using water fasting or calorie restriction wouldn't necessarily be the best way to get them into a fasted mimicking state. I would much rather them be feeding their normal cells feeding themselves good micronutrients, vitamins, minerals, amino acids, fatty acids to get their normal cells operating better while they're going through therapy. I call it a weight balancing diet because yes, if you are overweight, it will help you burn fat that you have on your body. When you are underweight, it actually helps you build lean mass. And so we know that there are body composition improvements in patients who follow ketogenic diets. Even in cancer patients, we've seen some of that with increase in lean mass, increased bone mineral density, increased overall mass. So some of our head and neck cancer patients or GI cancer patients that do have problems with weight maintenance, especially during therapies, we've seen on ketogenic diets that they can actually gain weight. So I will say that there are some times where patients need to really focus on getting in adequate calories, getting in adequate fast. Sometimes when you're going through chemotherapy, if you are suffering symptoms from that chemotherapy, a lot of times you just don't feel hungry. You feel nauseous or something where you're not eating. So we have to utilize the days that we're feeling good to try to build back and build up. But one of the common mistakes when people start a ketogenic diet is they just do a low carb diet, meaning they just start cutting out carbs, but they're not actually eating any fat. They're eating chicken breasts and salmon, which great, fine. But then they're not adding enough fat. So now they don't have carbs and they don't have fat and they have no energy and they feel terrible and they're wasting away because they need to eat something. They need to get energy somewhere. So it is about education. It is about don't fear the fat. It is about choosing fattier cuts of meats and eating whole eggs, never egg whites and things like that, where we're really trying to optimize the fat that they're taking in, which is now going to replace typically a high carbohydrate diet. But not everybody is eating a high carbohydrate diet, but most are. Healing. Anybody who's gone through a surgery and has to rebuild and repair, we're in a slightly higher use, right? We need more amino acids. We need more building blocks during times of repair. And while we're going through cancer therapies, that's a constant repair process. We're always trying to heal our normal cells in between each cycle of chemotherapy, in between each dose of radiation. So the more we can do to help support our body during that time. And yes, so sometimes it comes to scheduling. Like, I'm sorry, I know you don't feel like eating and I know you only want to just have this one little drink and you call it a day, but that like eating now is your job. Like this is how we have to do it to kind of pull you out of that hole. I was dealing mostly with women's cancers like breast cancer and endometrial cancer, which are very highly associated with obesity. So my whole practice originally was, can I get patients to lose weight and trying to employ some form of low carbohydrate diets to do that. There's data that says even if you're obese or your normal weight, it really comes down to insulin. It's not about the obesity. I usually say if you are carrying extra weight, I know that insulin is too high in you at times. It may not be too high. If I did a fasting insulin, it might still look. So after fasting overnight and getting a morning insulin, it might actually look okay. But if you're carrying extra weight, it means that insulin is being active during the day because insulin is what is creating that fat storage. Interestingly, there was a study, observational, that came out a few years back showing that, why is obesity seem to be protective in the younger breast cancer or younger woman population? They had less breast cancer, but obesity when you're older, postmenopausal, seem to have much higher risks of breast cancer. And if we think about it from a storage perspective, so maybe we're having ups and downs in insulin, but our fat cells are still taking up fat pretty easily. So we don't need excessively high insulin levels. We're just glucose comes in, insulin is released, Glucose and fatty acids are put away. Our cells are still receptive. So then insulin drops back down. So it's only going up kind of after we eat and it's coming back down. But as we do that over and over and over and over, so decades of that, well, now our cells are like, there's no more room at the end. You need more insulin to push and push and push that in. It doesn't happen. So as we age, we become more insulin resistant. So it seemed to go along with that insulin resistance piece where we started to have elevated insulin. But again, the researchers didn't understand that metabolic feature. So they just said, oh, and I was with a group of, breast cancer physicians saying, I don't know what this means. Fat's okay. It's good for you when you're young. It's bad for you when you're bad, being obese. It's like, well, no, that's not. It means we're on the wrong path already. But we tend to get more insulin resistant as we age. And sadly, in our today's population, everything seems to be starting earlier and earlier. So what used to be a postmenopausal disease is now a midlife disease, even an early life disease. I always still recommend getting a, overnight fast set of blood work on a routine basis. And if you're otherwise healthy, you might only do that once a year. Others might need to do it more routinely. But I will look at not only insulin and glucose, but also the interaction between the two. So there are some calculations that we can look at. I will also look at fasting triglyceride levels. So triglycerides are the fat that's in our bloodstream. So we have, again, two fuels, glucose and triglycerides or fat. And if both of them are elevated, there's a big problem. If one of them are elevated, there's still a problem. But again, it's the balance between the two. And I will also look at triglyceride HDL ratio. So HDL, one of the cholesterol markers, but triglyceride divided by HDL is another way that we can look at insulin resistance. So I try to look at all three, and those three can give us some guidance. If any one of them are abnormal, again, in my range, not in a conventional range, then we know that there's some degree of insulin resistance. If all of them are normal, but I have signs in a patient, maybe they have a lot of in-between meal, hunger, anxiety, like they have a lot of the symptoms, the hangry symptoms that people will often comment about. But if they can't easily skip a meal, many people don't want to skip a meal, but if they had to, they could, and they would still be functioning fine. But if somebody is walking around going, I need food right now because I think I might die, that is a sign of significant insulin resistance, actually. Insulin is still on and pushing that glucose down. So I do have some people, typically in my younger population, that still have fasting numbers that look okay. But when you really question them about how do they feel, what about brain fog, fatigue, all of these other symptoms, you think that there's probably something hiding in between the fasting numbers.